Three.
Hello, Nursing 450 Nursing Leadership. Today, our group is happy to present to you our presentation on access to care. We will be discussing Americans' access to care, some barriers to receiving care, but also what we felt was the largest barrier was lack of adequate insurance coverage. We will share with you our position statement, provide with you our theory that guided our research, relevant research and statistics related to access to care, an expert interview, and our action plan to help improve access to care. Michelle Cho, Khalif Dantzler, Victor De Leon, Nicole Escalera, and Bonnie Ferreira.
United States ranked number 1 for gross domestic products in the world again in 2017. America is wealthiest country in the world, but we are not offered universal health care for the citizens. There are 32 countries offering universal health coverage globally. In 2010, President Obama signed Affordable Care Act, which is close to universal health care, but not full universal coverage. Insurance companies cannot deny insurers due to pre-existing condition, age, or gender, and all individuals are mandated to get coverage regardless of their income. For individuals with low income, government subsidies were available to lower the cost of insurance. Penalty will impose for insurance companies denying coverage, and individuals will tax with penalty with no insurance coverage. With Health Affordable Care Act, uninsured Americans decline dramatically. CDC reports on uninsured Americans dropped from 16% in 2010 to 9% in 2016. However, the number is equivalent to 28.9 million Americans without health insurance. The biggest drawback is high cost of insurance, high cost of copays, and coverage of unnecessary services.
Our position statement is, we believe all Americans should have access to universal health coverage. As Bonnie and Michelle discussed, many people are denied the right to health insurance due to circumstances beyond their control. Some of the factors that hinder adequate, equitable, and timely access to quality care include insurance coverage or lack thereof, financial resources, homelessness, mental illness, transportation, language barrier, proximity to healthcare provider, discrimination, cultural beliefs, cultural disconnect, health illiteracy, immigration status, and others. These factors lead to health disparities, which can contribute to higher rates of illness, disability, and death in minority and underserved communities. Our presentation will discuss access to care as one of the largest barriers in depth and consider the contribution that nurses as leaders in the healthcare system can make toward improving access for all.
Our focus as nurse leaders should be on improving access to care by improving availability and affordability of health insurance. To accomplish this, it would be necessary for us to do more than to lead within our healthcare organizations. Making these changes requires changes to our healthcare system as a country, not just our healthcare organizations. Lateral leadership is defined by a dynamic approach to leadership. Lateral leadership focuses on networking, constructive persuasion, consultation, and coalition building. Lateral leadership would require nurse leaders to work within and out of their healthcare organizations with local, state, and national representatives to improve access to care by improving health insurance coverage. Once changes have been implemented, it would still require the nurse leader to work within their organization to ensure that these changes are reaching patients. Improving access to care through health insurance coverage is a huge problem to tackle, and it will take a multifaceted and dynamic nurse leaders to help make these monumental changes.
Today, there is still a significant number of people that are uninsured. That number is currently 28.9 million people that are uninsured. Before the Affordable Care Act was passed in the year 2010, there were 48.6 million people that were uninsured. One of the principal reasons that many people are uninsured is because of the high cost of health insurance. Many uninsured people come from working families who essentially are in a gray area of affordability. They make too little money to be able to afford health insurance out of pocket and make too much money to qualify for government insurance programs like Medicaid, also known as Medi-Cal here in California. Young adults in the age range of 18 to 35 years old cannot afford health insurance because they don't make enough money. Administrative costs in U.S. hospitals are the highest than in any other nation. This is also part of the problem of the U.S. healthcare system. High hospital administrative costs have an impact on insurance plans and make the plans less affordable for many people because it drives the prices up. Additionally, consumer-directed plans have been found to have high deductibles. There is particular concern regarding healthcare access for families with low incomes or family members that have high-cost chronic conditions who may face higher costs under consumer-directed plans. Low-income families that have employer health insurance are moving their children to public health insurance options. This is due to insurance premiums that continue to increase. The average contribution to premiums for family coverage reached $4,565 in the year 2013. The uninsured can pay for primary care out of pocket, but they must pay cash, and discounts on price or flexibility of payment timing are often not an option. This leads people to skip care they desperately need. This also highlights what is already well known, that the uninsured receive less care, have worse clinical outcomes, and experience more financial burdens compared to people with either Medicaid or private insurance. The number of uninsured people will continue to grow unless universal healthcare for all is made available. More people are losing their employer-sponsored healthcare. From the year 2000 to the year 2015, there was a 9.9% loss of people who lost their employer-sponsored healthcare insurance. This is almost a 10% difference. There are significant disparities in access to healthcare as well. People that are poor, African American, and Hispanic are less likely to have health insurance. Universal healthcare for all would correct these disparities. The answer to getting healthcare coverage for the uninsured is universal healthcare. Universal healthcare would expand coverage to 28.3 million people. Universal healthcare coverage would have a significant benefit for the poor. They would receive considerably more in health services than they do today, with no out-of-pocket costs. Higher income people also would receive benefits of comprehensive insurance coverage with no cost-sharing requirements, and would no longer have to pay premiums for private coverage. However, their benefit improvements would be more modest given their current coverage, and they may find it harder to access providers because of supply constraints.
Next, we will discuss my interview with Rochelle Conger, who is Chief Operating Officer at the MLK Junior Outpatient Center. Unfortunately, I was unable to complete my original interview with Dr. Monica Soni, who is a primary care physician and Director of Continuity of Care at MLK, which is a DHS facility located in the Willowbrook area of Los Angeles, since she is on medical leave. However, on Tuesday, July 31st, I was able to secure an interview with Ms. Conger. Ms. Conger has been with MLK for 33 years. When asked why she chose this as her life's work, she replied, "I wanted patients to receive the best therapy, even if they could not afford to pay for the best." This facility services a safety net population, which before the ACA was predominantly Medi-Cal and uninsured. The Institute of Medicine defines safety net providers as those, by mandate or mission, who offer access to care regardless of a patient's ability to pay, and whose patient population includes a substantial share of uninsured, Medicaid, and other vulnerable patients. Now, almost everyone is eligible for coverage under the ACA. This interview was arranged with the assistance of my facilitator, Dola Akarele, nurse manager at MLK Outpatient Center. One of the first questions I asked Ms. Conger was, what will the changes that the current administration is trying to make do for the safety net population and underserved, predominantly minority populations, for example, those with pre-existing conditions? According to the AHRQ, provisions to increase health insurance options for young adults, early retirees, and Americans with pre-existing conditions were implemented in 2010. Ms. Conger states, the changes will hinder efforts to address health disparities for this population. Some will lose coverage and others will delay seeking coverage due to the inability to meet the financial obligations associated with their care, co-pays, share costs, pharmaceuticals, etc. The delay in accessing care may result in less favorable outcomes and premature death. Patients may also avoid seeking care because of fear of immigration or deportation. It is especially concerning the impact this will have on children and adolescents, those most vulnerable. As Bonnie stated earlier, the nurse leader must work diligently and collaboratively within their organization to ensure that they and their nursing colleagues and staff are supporting efforts to provide the best, most cost-efficient, evidence-based care for their patients, working to the top of our skill set, empowering patients and their families to become engaged and involved in their care and decision-making, continuous quality improvement, supporting a safe and just culture, and working to ensure customer satisfaction are ways by which we can succeed in this mission. Earlier, Victor reported significant disparities as referenced by an AHRQ report that stated Blacks and Hispanics were more likely to be uninsured than whites, though promisingly, Black, white, and Hispanic white gaps in uninsurance decreased over the 2010-2015 period, as well as improvements in having a usual place to go for medical care, which is a measure of realized access. Next, we discuss some of the innovative ways that MLK Outpatient Center addresses the barriers to access to care in this community. DHS is committed to identifying and implementing strategies to ensure success in fulfilling its mission. Here, I list some of the services that are offered at MLK to help expand access and support the needs of the community. More information can be found at their website listed here. The next question is the medical or healthcare community in support of or against an overhaul of the Affordable Care Act. Ms. Conger feels that the medical community, especially those that serve the underserved population, is in support of the ACA. They acknowledge that as it is, the ACA is not perfect, but things are better for these communities with the ACA than without it. Those not mission-driven support the ACA because of financial gain. This reminded her of the change that took place when Medi-Cal expanded coverage for obstetrics. Prior to the expansion, safety net hospitals had little competition for obstetrics. The number of births at each facility were astounding. However, after the expansion, safety net hospitals had to now compete for these same patients. This mural is on one of the buildings at the Charles Drew University, which is on the MLK campus. It is an image of Dr. Martin Luther King Jr. and a quote as shown here. The statement remains as fitting today as it was back in 1966 when he spoke these words. Ms. Conger and I discussed the future of the Affordable Care Act, and she expressed hope that it will remain, as well as reiterated her thoughts on its importance to all Americans. On the current administration, she shared, although they have been successful in weakening certain components of the law, it will not be overturned. The ACA is not perfect, but it has made significant difference to a large portion of the population that did not have coverage. With time, improvements will be made to address gaps and improve the Affordable Care Act. Ms. Conger also left me with a final profound thought, which sums up the needs of communities like Willowbrook across the country. In order to fully eliminate health disparities, the American Affordable Care Act alone is not the answer. All contributing factors, which include social and economic inequities, poverty, housing, employment, and education, must be addressed.
We must take action Everyone deserves to have a right to have access to care. As nurses, we have the ability to advocate for patients and their right to care, as nursing is one of the most respected careers. Nurses have the advantage of using their voices to speak up and take action. Nurses can get actively involved, ranging from writing a letter or making a phone call to local congressmen, legislators, or policymakers. For better chances of getting voices heard, nurses who advocate in numbers or within organizations such as the American Nurses Association will have a better chance for success. Then ANA at the highest level advocates for policymakers to recognize the true value of nursing and the unique perspectives nurses have to offer. Alone in 2017, the ANA was 3 times instrumental in stopping the passage of the legislation that would undermine the current healthcare delivery system, impacting nurses and their patients. Lastly, nurses can educate the public by working with organizations to set up public meetings and inform the public and how they can get access to care.
Thank you for listening to our presentation, and here are our references.